Hi class, my name is Emily Tippett and I want to first say thanks for being here and listening to my presentation. I really appreciate it. So first I want you to close your eyes and imagine, when you were a kid, what did you imagine that the year 2020 would be like? I kind of hoped that we would have jetpacks by now. But one thing that I didn't really imagine is that we'd have the ability to see a physician for a visit through a computer screen. And that's exactly what we have in the year 2020. So the area of telemedicine is very relevant to my specialty track, which is public health, because it's really an area of emerging importance and I believe has the ability to affect health outcomes of many different populations. And it especially has significance in the way that it improves patients' access to care. So through working in healthcare, many of us know that pediatric obesity is increasing in our country and quickly becoming a significant public health problem. According to the Centers for Disease Control and Prevention, the obesity rate for children is about 18.5%, and that represents almost 13.7 million kids. Through working in healthcare, you also most likely know that obesity has a lot of long-term negative side effects. In one systematic review by Riley and Kelly, done in 2010, it showed that kids who are obese have a long-term increased risk of premature mortality from cardiometabolic causes. When I was a pretty new nurse, I started working at a pediatric endocrinology clinic in Wichita, Kansas. I learned a lot of things while I was there. One of the things that really significantly struck me was to what great lengths parents have to go to get their kids to appointments. Many of the patients that we were seeing in our diabetes prevention clinic live several hours away, and coming to the clinic for an appointment even once every 3 months, missing a whole day of work and school, it just really wasn't feasible for a lot of families. Not to mention the cost associated with all of that. So I don't think that my experiences there were isolated. Because according to the CDC, living in a rural area really puts you at higher risk from dying from all of the leading causes of death. And according to one source, in urban areas, there are 134 subspecialists for every 100,000 people. But in rural areas, there's only 40 subspecialists for every 100,000 people. And it's also important to note that this was a study done with adult patients. So when we think about pediatric patients, those numbers are probably even more significant disparity. So all of this leads to me developing my PICO question, which is listed there on the slide, but I'll read it to you. Is the use of telemedicine appointments for multidisciplinary monthly weight management appointments effective in decreasing BMI in rural pediatric populations within a 6-month time frame compared to patients who have face-to-face appointments? So in my question, telemedicine appointments are the intervention, changes in the BMI are the outcome, rural pediatric patients are the population, and 6 months is the time frame. So the next step in this process for my question was to review the literature. I did this first by searching CINAHL, the Cochrane database, EBSCOhost, and Google Scholar, using the key terms obesity, pediatric obesity, telemedicine, telehealth, rural, and rural medicine, body mass index, and BMI. I was able to find 3 systematic reviews, which are level 1 evidence, 2 randomized controlled trials, which are level 2 evidence, and multiple other studies which represented level 3, 4, and 5 evidence. So I was excited about kind of the variety of evidence I was able to find. So I just briefly wanted to mention some themes that I noticed in the literature. The first theme that I noted was the lack of access to care that rural patients have. One study completed by Duthit, Kive, and Biswas in 2015 found that rural patients compared to urban patients had difficulty maintaining health services on par with their urban counterparts. That's a quote from them. According to another study and that's completed by Gudbranson and others in 2017. 1/10 of physicians are practicing in rural areas, despite the fact that 20% of the general population live in those areas. The American Academy of Pediatrics in 2015 published a medical needs assessment, and in that they noted that families living in rural areas have multiple barriers to obtaining subspecialty care, including long distances that had to be traveled, as well as absences from work. And the second theme in the literature that I noticed, and I think the one that was really most relevant to my PICO question, was whether or not telemedicine is an effective obesity treatment or intervention. So in a helpful systematic review by Huang, Lin, and Wu in 2018, they found that the telemedicine group that they studied compared to the face-to-face group had significant reduction in BMI. And similarly, Lipana and others in 2013 found in their study that the telemedicine group experienced 69% weight loss or maintenance compared to the face-to-face group, in which only 44% of those patients achieved one of those goals. In a pediatric study, Davis and others found that their telemedicine intervention group had weight and BMI outcomes that were at least on par with the face-to-face group. Brown and others completed a randomized controlled study that showed using an integrated care model, which included subspecialists working in conjunction with a primary care physician, at 6 months showed decreased BMI values. And then finally, another study, Fleischman and others found in a randomized control trial that those who had telemedicine appointments in the group that they looked at had notable decreases in their body mass index. A third theme, excuse me, that I noticed in the literature was that patients were satisfied with the telemedicine care that they were receiving. So Davis and others in their study found that patients reported that they were very satisfied in the care they received and actually attended 100% of their appointments. Similarly, in another study, 751 families were interviewed, and the authors found that the families had high interest in telemedicine, especially those families that lived further away from the urban subspecialists. In a third study, families, when compared to face-to-face appointments, had similar satisfaction rates with telemedicine appointments. So after reviewing the literature, my hope would be that in the clinic I was seeing these weight management patients, that a team could be developed consisting of an RN coordinator, endocrinologist, dietitian, who would work in partnership with the primary care physician and their staff nurses. So the idea would be first to identify qualifying patients. That could be done through the use of an EMR search, and where you would narrow that down by diagnosis, and then also identify which of these patients would have primary care physicians who would like to participate in the intervention. After these primary care physicians were identified, the RNs working in those offices would receive training on obtaining the BMI measurements, and then ideally the hospital IT department could work with those offsite locations to make sure that they were set up for telemedicine appointments and had that technology in place. So the team would start with some baseline questionnaires for patients and families to help gather that baseline data. So the theoretical framework that I feel like is the best for my question is the technology acceptance model. So following this framework would allow the team to assess staff members who are part of the team to see if they're in a place that they can fully embrace that use of technology in telemedicine. And then it would also allow the team to assess families to see if they are accepting of the technology of telemedicine. If our key stakeholders aren't in a spot to accept the technology, then the basis of our practice change is really not possible. So that would be really important. So there are a couple barriers for the intervention. So the first limitation would be financial. Implementing a telemedicine intervention can be costly. The clinic where I recommend the practice change already has telemedicine capabilities, but getting that in the primary care doctor's offices would be potentially a challenge. Through my kind of review of the options out there, there are some telemedicine options that are fairly affordable. For instance, one of those is Zoom for healthcare, and that starts around $200 a month. One thing, and I don't really have time to go into this a lot, but insurance reimbursement for telemedicine is often less than what you would receive for a face-to-face appointment, so that could also be a barrier and limitation to implementing this practice change. A potential barrier for families would be a language barrier. A lot of these families that I had worked with in my clinic were from Western Kansas, and quite a few of them require Spanish interpretation, so that would be really important to keep in mind that we have a very qualified medical interpreter available for appointments. An ethical consideration to keep in mind would be ensuring that families receive informed consent that their appointment will be through telemedicine, and that we are reassuring them that their health information is being kept safe. Being on a screen can feel a little uncomfortable, and so assuring them that it's not being recorded would be very important. So outcomes and evaluation. In my practice change, we would assess the data, BMI data at baseline, including height, weight, and we would use that to calculate the body mass index. So we would then collect data at every visit monthly, including our final visit at 6 months, we would collect that. So we would then analyze all our data and really hope to see reduction in body mass index. Ideally, it'd be great to see reduction in BMI in at least half our patients, seeing that they had improvements. I also believe in outcome evaluation questionnaires for families and the primary care physicians, asking them about their satisfaction with the technology that was used and the acceptability of the technology to them would be really important and very helpful data to have. So when I think about future recommendations and future ideas for telemedicine and treatment of these patients, I believe we need more randomized controlled trials that look at pediatric patients who live in rural areas and seeing what their outcomes are for subspecialist treatment. And I also believe that the data that we currently have available points to the fact that these interventions are helpful. And so I think trying to expand the use of them, and I really believe that the partnership between subspecialists and primary care physicians could be a really great area to emphasize to really expand the access of care for these families. It takes away the burden of cost and travel time for our families, and overall can just be a really beneficial thing for this population. So thanks for listening to my presentation, and let me know if you have any questions. And then you can see my references at the end of the presentation here. Thanks so much.